talking about brain metastases and how I see that's the management is changing over certainly my career. And I guess in keeping with the theme of the night of frontiers of radiation medicine, some of the game changers that I see in the next 5 years. So in terms of my disclosures, they're up there. And Pez already thanked Arjun for being a mentor for me over the years. So we all know the significance of brain metastases, you know, particularly in Australia, the number of patients with melanoma brain metastases, but significant proportion of our patients with cancer develop brain mets. And given the effectiveness of systemic therapies, it's only going to increase over time. The other factor here is access to MRI scans, which means we're picking up metastases earlier, and that's going to have an impact on how we manage them. And we all know that uncontrolled CNS disease is a source of often the mortality, but also morbidity for patients. I think it's fair to say that historically the approach to brain metastases has been somewhat nihilistic, irrespective of patient performance status. They're almost invariably offered whole brain radiotherapy with a range of dose fractionations. It's important to note that this was just a palliative procedure and there was never an intention to have durable control of those tumours. And so this is what we've learnt with regards to whole brain radiotherapy over the years. We know that yes, it improves survival compared to historic controls, has some reasonable response rates. But I guess what's important is that irrespective, the median survival of these patients is poor. And with whole brain radiotherapy, almost all of these patients die a neurologic death. We also know that it has significant patient impacts and the things that patients report with whole brain radiotherapy, the fatigue, headache, nausea, and it has demonstrable impacts on patients' cognition, verbal learning, and general quality of life. So I think it's fair to say that previously we've lumped them all together, but we now have the understanding that it is actually a heterogeneous group, these patients with brain metastases. And these are the factors which are obviously important on the left, but I just highlight, based on histology, what we've boxed in the right over there. And this is that a number of these patients are living more than a year. And I guess that's important when we're starting to look at how we manage these patients, both from a treatment effect and also toxicity point of view. It's pretty obvious from a scan like this that these two patients are going to have different outcomes. And it's been well documented now, and these are the survival curves showing that for patients with good performance status and other prognostic factors that are good, they can actually have a very good survival. And for that reason, when we're looking at the treatment and what we're offering these patients, we need to look at firstly survival, but also quality of life. And in doing that, we need to start looking at the durability of intracranial control and the toxicities of our treatments. So when we're talking about patients with limited brain metastases, now the definition varies between 1 to 3, 1 to 4, 1 to 5, but there is still a role for local therapy in these patients. Obviously, surgery and radiosurgery being the two modalities used for local treatment. And although there's no good head-to-head trial, I think for lesions less than 2.5 or 2 centimetres, outcomes are likely equivalent in terms of local control. In terms of radiosurgery, just so that we're all on the same page, it's, you know, SRS or stereotactic radiosurgery comes from the 3D coordinate system. Obviously that has changed over the years also, but the radiosurgery is giving that destructive dose of radiation. Now, I always highlight in all of my talks is that this is distinctly different to radiotherapy, using high doses with an ablative intent as opposed to radiotherapy. Obviously, there's a number of machines that can be used to deliver stereotactic radiosurgery. This is the previous Linac machine that I used to use for my intracranial work. There's also the CyberKnife, which is available. And as you're well aware, we've recently invested in the Gamma Knife Perfection unit. The principles, as I said, is to non-invasively ablate lesions using single high dose and sparing as much of the normal brain as possible from any radiation toxicity. In our meetings, we always have the discussions about whether to offer surgery or radiosurgery, and I think we need to start thinking about them somewhat differently. There's always going to be a role for surgery, particularly in larger lesions, in patients who have significant symptoms because of mass effect, and there's a significant proportion where surgery is required to just attain a tissue diagnosis. But in terms of radiosurgery, smaller lesions, multiple lesions, particularly if they're small and asymptomatic or in surgically difficult to access locations, that's where radiosurgery really comes into its own. And obviously the other advantages of radiosurgery, which are hard to quantify, is that it's typically an outpatient day procedure, shorter recovery, which means these patients with advanced cancer can get onto their systemic therapy straight away after treatment. In terms of surgery, a snapshot of the data for surgery, we all know that surgery improves survival for patients with a solitary brain metastasis. We also know that whole brain radiotherapy after surgery improves the local control and distant control but has no impact on overall survival. And so this is a patient that was seen in my clinic who was always someone that we would consider surgery up front. Large lesion causing symptoms, had a good surgical resection. We know from the published literature of patients that have had surgery and observation that a lesion like this is at high risk for local recurrence. And that's really started to make people think about the way we manage these patients, where previously we would have just given this patient whole brain radiotherapy, where now I think most people would consider giving this patient localised treatment to the surgical cavity to increase the chance of tumour control, but not subject the patient to the adverse effects of whole brain radiotherapy. So, like Arjun, I use a hypofractionated stereotactic approach. Just to prove that I was a little bit different, I went with 3 fractions as opposed to his 5 fractions, but in effect delivering the same treatment. In terms of radiosurgery, there's a lot of randomised evidence out there showing its effectiveness. Like surgery, improves overall survival for those with a solitary lesion. As the METs get up to 2 to 4, it still has a significant role to play in terms of reducing steroid dependence. But I just highlight the fact there that neurologic death is somewhere in the studies 10 to 25%, as opposed to 90% when patients are treated with whole brain radiotherapy alone. And we know now from a number of studies that whole brain radiotherapy after radiosurgery does not impact on overall survival, and I'll talk about that just a little bit more. I don't think that this is controversial anymore. I think that the evidence is there for us to drop whole brain after radiotherapy. It makes sense in those patients who have a favourable outcome. And the rationale is quite simple, is you don't subject them to whole brain, you put them on an ongoing surveillance program and with MRI scans and pick up recurrence early and offer appropriate salvage treatment. And you can avoid whole brain radiotherapy in up to 70% of these patients. So in terms of what the evidence has told us, we know that omitting whole brain does increase the distant recurrence rate after radiosurgery, but that does not impact on overall survival. And we know that whole brain radiotherapy definitely impacts on patients' quality of life and neurocognition. So if there's a take-home message from part of this talk, it's that for solitary brain metastases, local therapy is indicated, whether that be surgery or radiosurgery. For patients who have a larger number of metastases but with good performance status, radiosurgery alone is the preferred option. And that's why there's been a number of professional groups that have put out guidelines recommending that approach. I put this up. This is obviously Arjun's meta-analysis, which is, I think it's thought-provoking and probably asks us a lot more questions in that Arjun got the individual data from the three of the 4 randomised trials of SRS with or without whole brain and looked at the impact on survival. And it confirmed what we already knew, but what I found most interesting is the survival benefit for those people younger than 50. There's lots of reasons why this may occur, and I think one of those is likely the fact that after radiosurgery alone you can get these patients back on the systemic therapy straight away, so reducing the time for them to get on the systemic therapy, bearing in mind that the majority of these people are dying an extracranial death, no longer an intracranial death because of radiosurgery and intracranial control. So we get caught up on numbers, and it's something that we need to change. We think about these patients of 1 to 3, 1 to 4. But this is the data from Japan with Professor Yamamoto, well known to a number of you, where he looked at a huge number of patients that all underwent SRS. And what is the most significant thing out of this paper is that number of lesions is not the be-all and end-all. In fact, it's probably the volume of disease which is more important. And the patients who had greater than 5 METs did not do any worse in terms of overall survival. And I also just highlight the point here in terms of the neurologic death rate. So once again, we're seeing with aggressive intracranial control, these patients are dying from their systemic disease. And as we get more advances in controlling systemic disease, it's reasonable that we're going to improve overall survival in these patients. Obviously, radiosurgery is not the only way to try and avoid the negative impacts of whole brain radiotherapy. A lot of people look at hippocampal sparing whole brain radiotherapy. It certainly has a role to play. Personally, I don't do it a lot. But there is evidence in a phase 2 study that it is better for patients in terms of quality of life, but that's compared to historic controls. But it certainly has a role to play somewhere. I just don't know where it is. So in terms of whole brain radiotherapy, it does have a role to play. I say a definite role in multiple METs poorer performance status, but I'm sure many of you are aware of that there's data now that some of these patients do just as well with steroids alone. So I'm not convinced that in the poor performance status patients that it has a great role either. But in patients with lower GPA, I think that it's reasonable to offer whole brain radiotherapy. There will be a proportion of patients who have multiple METs after radiosurgery where further radiosurgery may not be feasible for a variety of reasons, and whole brain is completely appropriate. And where I see another role is multi-progression in the setting of CNS penetrating systemic agents. And that's what I want to talk about next, because what I see is in terms of frontiers of medicine in the management of brain metastases is how we sequence our radiosurgery with these agents that are now available that have CNS activity. So we all know melanoma, lung, and there's some agents in breast cancer that have CNS activity. Now, at risk of offending any medical oncologists in the room, I understand why they're a bit excited about this, but the hard reality is the response rates range between 20 to 50%, and we need to bear that in mind, particularly based on lesion size and lesion location. The complete response rate is actually quite low, depending on the agent, 0 to 15%, and the duration of response is somewhat variable depending on the agent. That being said, this is completely appropriate in small volume disease, and obviously the great benefit as opposed to whole brain radiotherapy is you're treating the whole brain with relatively low neurotoxicity from these agents. And I think this is a letter from Nature which has kind of changed our way of thinking about the brain, where previously we used to think of it as a sanctuary site, where now there's good evidence that it's not devoid of immune response. So these immune modulating agents do have activity in the brain. And this is some of the early preclinical work that was done, which is it's quite an elegant study. They inserted tumours into mouse brains and looked at radiation, stereotactic radiation, with or without antibody, the PD-1 inhibitors. It showed better local control with radiosurgery and PD-1 inhibitor, but what was more interesting is they then injected tumours into the abdomen and saw the abscopal effects, so the outer field effects, by doing radiosurgery with a PD-1 inhibitor outside of the brain. So biologically, there is a rationale in terms of improved local effects, but also the potential for almost vaccinating the body by doing radiosurgery in the brain in conjunction with PD-1 inhibitors. And this is something that we're actually seeing in the clinic. We see quite a lot of melanoma, and you can see in the 2 panels at the top, a patient with the bulky temporal and a pituitary fossa met. And this patient treated early on, this was a couple of years ago actually, 18 months, with radiosurgery and a PD-1 inhibitor. And we are seeing these exceptional responses, both locally and sustained responses in melanoma with PD-1 inhibitors and radiosurgery. I do say that with some caution, in that we need to be careful about radionecrosis and inducing these effects when we're using these agents together. But certainly sequencing of these agents is going to be important moving forward in managing these patients. So currently where we're at, and I think some of the future directions, trials are no longer going to be mixed bag trials. It's going to be single histology and even, I would say, mutational driven trials. In terms of patients with limited brain metastases, I think that radiosurgery alone in patients with a favourable prognosis is the new standard of care. But where I see some of the interest is multiple brain metastases and how we sequence radiosurgery with some of these targeted agents. It certainly makes sense. What is this all going to translate to? Well, there's no doubt there's going to be greater utilisation of radiosurgery. And so people with a significant brain workload and a radiosurgery program need to start making arrangements to kind of address how they're going to meet this need. And there are ways to do it, both gamma knife solutions and LINAC solutions. And you can't have a talk about radiosurgery but not actually talk about the fact that there is a difference between these two. I'm not going to get into an argument about dosimetric differences. It depends on whether you use an MLC-based, cone-based, number of lesions, size of lesion. But I think that there is little doubt that, from my experience of having done this on a LINAC and now doing it on a gamma knife, there are definite advantages in our department in terms of workflow, patient convenience, and having a dedicated intracranial unit so that I'm not fighting for machine time with the breast cancer patients, the lung cancer patients. So that's why we invested in the gamma knife perfection, because we have a significant intracranial radiosurgery program and load, and we wanted to have a dedicated intracranial solution. And there's no doubt for us as a statewide service where we're draining a big area, having that solution as a one-stop shop in one day is very important for our patients. I do make a note that I do think that down the track we may see some benefit dosimetrically as opposed to doing single ISO VMAT radiosurgery for multiple lesions, because I think with the immune inhibitors we do need to be wary of that integral dose to the brain. So having that steep dose drop-off with gamma knife, effectively multiple isocenter treatment, may have some dosimetric advantages in that setting. What I would say is as important, if not more important, is having a same-day workflow. You can see the picture. This is a difference of 14 days. Now, I know there's a lot of people out there that have different radiosurgery programs or stereotactic programs where they do planning and then treatment may be a week or 2 weeks down the track. And actually, our experience from our patients that we've treated, around a third of patients will have a significant difference on their game day MRI as opposed to their MRI scan, even if it's done within a few weeks. So you can see this is a 2 weeks difference, and a patient in 10 days had what we thought we were going to be treating 5 metastases, had 8 metastases on game day. So I think having a same-day service is important. I put this one up because it's kind of interesting. This is just a picture of a patient who'd failed 2 lots of whole brain, was in his 40s and still working. I treated 21 supratentorial METs, and this is not to talk about number of METs that you can treat. You can treat this with multiple things, but I guess what it highlights is that absolute number is not everything, but also if you look at the metrics down the bottom here, the volume of brain getting the effect of 1 fraction of whole brain is less than is 10%. So you can, a lot of people will say when you're treating 21 lesions in the brain, aren't you effectively giving that patient whole brain? Well, the answer is no. That patient got less than 1 fraction of whole brain to 10% of the brain. So in terms of where we are currently, I think that we've got an established role of radiosurgery in both the limited metastatic brain scenario and also the multi-mets. I think that whole brain and hippocampal sparing whole brain does have a role, but that still needs to be defined. Sequencing with the systemic agents is happening now, but we really need to be the drivers of trials in this space, because without trials we're not going to get the right answers. And I think that in the future what we are going to see is treating more patients with multiple METs, sequencing with those systemic agents to get not just in the immune therapy era, not just increased local effects, but potentially getting out of field and enhancing the systemic effect by doing brain radiosurgery. And for that reason, the gamma knife suited our needs in terms of having that dedicated intracranial solution with that same-day service. So that's basically the reason why we invested in it. So that largely concludes my talk, but I just want to thank, obviously, my colleagues that I work with, a great bunch of therapists, physicists and neurosurgeons that I work with, and also our nursing staff. So thank you. So good question. In terms of The superiority. We know the superiority of radiosurgery alone in, the limited metastatic potential. So I can't sit here and say I know that it's better in the case of multiple brain metastases. There is I believe there's a randomised trial going on at the moment of gamma knife versus whole brain in that 5 to 10 brain mets. It is pretty clear to me that we know that whole brain is not effective in patients that we think are going to live for any length of time. Now, it may still have a role in those that may live only 3 to 6 months, but I think if patients are living more than 6 months, I think that the role of whole brain is not well defined, and we know that radiosurgery, even in that setting, reduces their neurologic death and doesn't subject them to the whole brain radiotherapy. I'm confident it doesn't harm the patient, that's for sure. I think it is happening. It may not be happening at the rate that the believers or early adopters would like it, but I think that it's going to be driven through the profession. But I guess part of it too is, like anything, engaging community, and often that can be done through trials. So I guess what I see as the way to change it is setting up trials with multi-met scenarios, and then getting the consumers on board, supporting the trials, and then you get that groundswell, and then the people delivering the treatment can't ignore that. So that's basically what my approach is going to be. I think we need to open up multi-met trials, doing radiosurgery, accrue to those, show its effectiveness, but more so get the word out there. Much with the PD-1. What I've seen a few, it's the old story with melanoma. Melanomas bleed. Even when you treat them, sometimes they bleed. But we've also got a cohort of patients that have been on trial getting it's PD-1 alone with brain mets, and some of them bleed. So sometimes those hemorrhagic melanomas, it's hard to say whether it's treatment effect or what, but what I'm seeing is even when they're not getting radiosurgery, you're seeing similar effects. So I'm not actually convinced that we're going to get enhanced radiation necrosis with the PD-1s, but I'm certainly keeping an eye on it. And I'd be wary, like treating brainstem lesions and stuff like that. The caveat for my answer is that I work in a public institution and I have bounds placed on me because of that. But I wouldn't typically treat 40 lesions de novo. If it was my brain, I would probably do it. That's the reality. I wouldn't have whole brain. As long as I have a volume of less than, say, 15 cc's of brain mets, I would have gamma knife to all of them. So for me, it's a volume and whether radiosurgery is feasible or not. And that's just based on dosimetry and safety. But you're right, we're picking them up. The evidence is not there yet, but at least people within the Gamma Knife Consortium are going about to try and answer those questions by setting up the trials. It's not just METs, but I do a lot of benign stuff, and it was pretty hard to argue on a LINAC with my colleagues that I need to take up one afternoon a week treating acoustics. It's a hard argument when you've got constraints. So that is the advantage of having an intracranial only solution. I don't have to fight with my colleagues. Just sit in my own little room. No, I think the issue that I struggle with the most is so you're talking responding systemically or in the brain? Systemically. No, I would not typically give that person whole brain. The thing that I struggle with the most now is a lot of my patients are getting drugs with CNS activity, and then when do we pull the trigger on doing radiosurgery? That's what I struggle with the most. And for me, it's a lot about location and size. You've seen that those agents, they're very well tolerated, so it's hard not to offer them in patients where they've got small volume disease in non-eloquent area. But if anyone's got a lesion in an eloquent area or it's of greater than a centimetre, I would be more keen to get the radiosurgery in up front. But that's certainly what I'm struggling with the most now in my practice, and that's where we need the trials. There is, but the caveat to that is if they progress, which they invariably do, you will then have to come back and treat them again and put them through the whole planning treatment process. And depending on location, that may cause a neurologic decline. So personally, I'm conflicted where I would not watch a MET, but the reason for that is when you're doing Gamma Knife, we use a rigid frame. Once you've got the frame on, you're treating. Now, the flip side to that is there's no size limitation with Gamma Knife. You can treat something that's, if you can see it on the MR, you can treat it. Now, with other solutions, Linac-based, obviously there's going to be a minimum size to what you treat. That's not the case with Gamma Knife. Should you treat it all? I don't know the answer, but it's hard not to treat it when you can see it. I think the approach has to be different. I think that you're never going to get it through arguing Linac versus Gamma Knife and not a specific Gamma Knife code. It's going to have to be a radiosurgery code. And people are married to their machine, so you're not going to be able to change reviewers' ideas of dosimetry. The only way to approach it, as far as I can see, is having something embedded in the wording of the item number that it's radiosurgery as a non-invasive alternative to surgery for selected indications. It's going to be hard to get it based on just METs alone, I think. Because, if you look at the data, it's now considered standard treatment for acoustics, cavernous sinus meningiomas, METs, recurrent pituitary tumours with cavernous sinus disease. It's established treatment, and in fact it is the most reasonable treatment and cost effective. So I think that there has to be thought put into the approach on how to do it, and that would be my approach. I don't know how others feel, but it's a difficult one. So we've actually set one up at PA. So the first one we're going to look at is acoustic neuroma. And we're doing that so we've hooked up with QUT to do that, and after that we're hoping to roll it out through a number of sites. So we want to produce the cost effectiveness data so that we can then go to MSAC. That's just historical, because obviously there's other countries where there are Gamma Knife specific codes, but I think most people are in agreement that you need a radiosurgery code, and that it obviously needs to be a lot more than what it is right now. Yes. So we've done the figures in our department in terms of reimbursement costs and what's the real cost, and to break even you need to be hitting $300 to $350 a year just to break even as a service.
Thank you very much.
Pleasure. Thank you.